Hello everyone, my name is Hannan from Addis Ababa University Medical Faculty, Division of Pulmonary and Critical Care Medicine. So I'm going to talk today on COVID-19 and ongoing challenge. Unfortunately, we still need to talk about ongoing challenges related to COVID-19. So this is going to be my outline. I assume everybody knows about the clinical manifestation and epidemiology. So I will start my talk with virology and the subtypes and the virulence of the different virology variants in COVID-19. Then what are peculiarities in diagnosis and current management, summary of the current management as of March 2022, therapeutics and added therapies, then future consequences and challenges related to COVID, including long COVID. So this is the virology. It's a simple virus. It requires a host to replicate. It's single-stranded RNA, and it is encapsulated by N protein. So the focus is on a spike protein, because the spike protein is where treatment as well as vaccines are being developed. So it has two parts. I'll come into the details later. So the other is the envelope and the membrane, the M protein, which is a predominant protein, and it ensures incorporation of the RNA strand into the newly replicating viral particle. Now, let's have a closer look of the virus. So as I said, there are four important proteins we talk about: the spike, the envelope, the membrane, and the nucleocapsid. If you look at the spike, has two parts, the S1 and S2, where the S1 helps for the entry to the host tissue. And all this is called receptor binding domain. That is a very important component. And this receptor binding domain binds to angiotensin converting enzyme receptor 2, which is available on the lungs, heart, kidneys, intestines. So when you come down, then you would get the viral envelope. So this viral envelope is a component from a human membrane, and it's a fatty tissue. And this is where actually, while we hand wash and the soap kills, lies this envelope. Below it, you can see the capsid. It's a protein which shields the nuclear material. The nuclear material, the N protein, it's tightly bound to this single-stranded RNA. And this single-stranded RNA, then it has multiple locations on it, where one of the focus here is receptor binding domain. So if we know the basic anatomy of the virus, then we talk about COVID-19 and variants. So variants, based on WHO definition, are classified into variants of interest. That is, these are genetic changes as opposed to the wild type initially identified in China that are predicted or known to affect the virus characters. So it is a prediction and a known fact before as a cause for transmissibility, disease severity, immune escape, implications related to diagnostic and therapeutic escape, and it is identified to cause significant community transmission or multiple COVID-19 clusters. So when we talk about naming, it also includes variants of interest. But the most important are variants of concern. So they meet the definition of variant of interest, but they showed demonstrated to be associated with one of the following. So either it increases transmissibility, which affects the epidemiology, it increases the virulence, or even it can change the clinical presentation, and it decreases its effectiveness in public health measures, available diagnostics, vaccines, and therapeutics. So the scientists fix on the established nomenclature systems These are GSAD, Next Strain, and Pango, and they are still remain for scientific research. But for the common understanding of the public, so the WHO and the task force decided to use the Greek alphabets. So when naming with Greek alphabets COVID variants, it might include variants of interest, but not all variants of interest change to variants of concern. So every one of us know about the alpha variant, beta, gamma. Definitely we know about the delta variant, but the remaining alphabets from epsilon to mu were also counted as part of variants of interest, but they did not translate into variants of concern. So the next new variant we'll talk about is initially was planned to be named new, but the word new looks like new, so they jumped that and they shifted to the next alphabet, which is G. But unfortunately, Xi is also a family name in China, and president of China name is Xi Jinping. So definitely for political reasons, Xi was declined, and now we are sticking on Omicron variant. We call it Omicron variant, and that is the dominant variant, which is continuing the pandemic. So the next variant, if WHO agrees, is going to be Pi, based on how nomenclatures are given. So these are the names of variants of concern. For your interest, the source is WHO. So first as opposed to 2019 in China of the wild type, then the next is the Alpha in the United Kingdom, followed by Beta, which started in South Africa, Gamma, Delta, and Omicron. But also there were variants of interests as well. Now, mutations are natural progress of any viruses, and usually mutations are actually detrimental for the virus, and it's a reason for the loss of those viruses and makes the viruses more weaker. But some of mutations, if given due time, and if they continue replication, which definitely affects the areas of spike domain in the genes, then can affect the translation of amino acid. So let's take an example. So this means amino acid 614s, which initially was supposed to be D, now changed into G. So they call it as a DUG. So this is one of a very common mutation. The other is what they call Nelly mutation. So in the 501 amino acid, the N is changed into Y. And the other is a YEK mutation, which the E at the area of 484 amino acid is changed to K. But let's look at the delta. So the delta can have, actually was found to have two more mutations, which are found in both in gamma and in beta variants of concern. But now the recent variant is Omicron variant. So Omicron variants not only have one or two changes, rather 45 to 52 amino acids were changed, either deletions or insertions. And among these amino acids, 15 were found to be in the receptor binding domain, where the monoclonal antibodies act, where vaccine antigens are developed, and so on. So the prediction was that it would be more infectious. So if you have more spike, if a virus has more spike proteins, then they would insert into tissues more readily than those who doesn't have more spike proteins. So it was estimated and was found to be true that it is more infectious and more transmissible, and it might actually resist neutralization by a vaccine, but also that was dealt and can have an effect to resist some therapeutics. So other issues related to variants is in the diagnosis. So as you know, COVID diagnosis can be molecular, so that's the gold standard, PCR by nucleic acid amplification test, but also you can do it by identifying different antigens on the viruses, and antibody tests have its own purpose, but not as a primary diagnosis. So considering the rapid shifts of the different variants, so there is a policy to evaluate the impact of this mutation on the COVID-19 test performance. So what kind of tests are necessary? So definitely we need a test which does not target only one genetic area. So we need a test kit, or we need a diagnostic modality which targets multiple genetic targets, and most on the market have actually multiple locations of the genome is represented. But based on the shifts, let's take this example, the variant B117 variant, which showed double deletion at position 69 in 70. If you use a test which detects the S gene, then you would have missed those specific variants of COVID-19. So with this change, you have to update, and there are bodies, as I said, and regulations which follow and approve the different commercial tests available. So the other modality of test is antigen test. So antigen test, it doesn't require amplification of the genome to identify it. So it requires a short time. It has a low cost and rapid turnover. So that it is a good test to identify COVID-19 in congregate settings, like in hospitals, where patients are very vulnerable. And if you want a repeat test, then that is a good test because the turnaround time is very short. But you have to know the drawbacks as well. Inherently, antigen tests can be affected if you do not follow instructions. So it is time dependent when you test it. So you have to follow rules. Storage of cartridges should be appropriate. And tests can be interfered by human antibodies like rheumatoid factor or other non-specific antibodies can affect this antigen test. And the sensitivity is actually less can be affected in communities which have low prevalence. So to summarize when and what to test based on the temporal consideration, we know symptom onset between the first and second week of onset, then the viremia load is very high, especially in the nasopharynx. But then if patient progress, then the yield would be higher in the lower respiratory tracts as well. So if you are going to use antigen tests, then the yield is likely to be higher in the initial week of presentation. But the PCR test can last quite longer because of a higher sensitivity. But when you go to weeks, later weeks, then you talk about antibody tests where IgM occurs early and drops fast, whereas IgG antibody, just like any other infection, occurs a little bit later but stays longer. Okay, now coming to therapeutics. I will not go into the details of therapeutics, but you have to know it's a very evolving area. So WHO have updated in March 3, 2022, the therapeutics based on evidences available. Within a day also, NIH, CDC also updated their guidelines related to therapeutics in COVID-19. So all the therapeutics depend on the clinical phenotypes. So early, we know it is a viral response. So it's a viral response, so anything we do or give treatment should focus on reducing the viral load and identifying individuals who are at risk to develop to severe progressive diseases. So that is the key, to identify this minor group of patients who are likely to progress to severe disease. So later in the second phase is pulmonary phase. So this in pulmonary phase, alveolar spaces will be filled. So features of change like shortness of breath are related to involvement more in the pulmonary phase. So we talk about and we monitor oxygenation, and we see on chest imaging features of pneumonia in the pulmonary phase. So these treatments, both viral treatment, antiviral treatments, and related to that, and some anti-inflammatory treatment can have an effect in this phase. But unfortunately, some group of patients progress to hyperinflammatory phase. So in these phases, you don't talk about mostly antivirals, but rather anti-inflammatories and immunomodulatory therapies at the stage of 3 or hyperinflammatory phase, where patients are critically sick, meaning requiring mechanical ventilation, ARDS, sepsis, and septic shock. So there are markers which suggest severity of illnesses. So among the markers, well proven is a D-dimer, which strongly predicts prognosis in this group of patients. Other markers like inflammatory markers like C-reactive proteins, LDH, and so on, troponin shows the systemic response, aberrant response for the initial viral infection. So treatments differ on the disease course, as I said, and adjuvant therapies and so on are beneficial throughout the course. Okay, so now the talk is on the 6 A's, the 6 A's of COVID-19 therapy. Those are anti-inflammatory, anticoagulants, antivirals, antibiotics, adjuvant micronutrients, and awake-prone positioning, based on the multiple evidences we found throughout these years. So risk factors are getting more and more refined. This is a little bit late slide. So CDC risk factors and WHO risk factors are quite different. But what you have to know is it is an evolving, it's an evolving assessment. So there are no strong studies which suggested that, but generally those who have underlying comorbidities like malignancies, obesity, COPD, and definitely diabetic patients, smokers, are considered to have an old age, age more than 65 years of age, are more likely to develop for severe disease. Now, management of COVID-19, because of logistical implications and because it's a pandemic and not everybody can be admitted, so management is grossly divided into hospitalized and non-hospitalized cases. So let's see. So this is the NIH latest description. So if patient for the first time is diagnosed, confirmed to have COVID-19, but does not require hospitalization or supplemental oxygen, so the strongest evidence is to give symptomatic management. So supportive care, antipyretics, and so on, and the goal of therapy is to reduce transmission. But then, based on the different evidences, which are the strengths are put in bracket here, based on the different strengths, new evidences have updated these guidelines. So let's start from what we have. So is DEXA required if patient is not on oxygen? No. So strongly against recommendation to use DEXA. Rather, DEXA in viremic phases can create a problem. So outcome might actually be worse for patients who took DEXA without requiring oxygen, meaning without involvement of the pulmonary. So pulmonary involvement is not there, patient does not require oxygen, so dexamethasone is not recommended as an outpatient who does not require oxygen therapy as a support. So other medication we have is remdesivir. So previously, I have some evidence here, previously The ACT trial was done on antiviral, so it was a breakthrough, and it was done on hospitalized patients. So it was an evidence because it's an IV medication given for 5 days, so it is done on hospitalized patients. But when you look closer to the data there, so it works more if it is given early, meaning in a viremic phase, less than 10 days, but benefit persisted with longer duration of symptom. But the largest benefit for remdesivir was for those who are receiving low flow oxygen. So another study done by Gottlieb and his colleagues has shown that they did a study on unvaccinated patients with COVID, and at least one risk factor for disease progression and onset of symptoms within 7 days before randomization. So they gave them 3 days of outpatient intravenous remdesivir, and they compared it with placebo. And what they found was hospitalization was significantly lower for those on remdesivir. Meaning for us, for simple understanding, it equates to a difference of 47 fewer hospitalization per 1,000 infections. So that is a significant number. So what does WHO recommend? So what does WHO recommend? So previous conditional recommendation was against remdesivir, as we know. So initial recommendation was only for hospitalized before, but they acknowledge that new data are ongoing and guideline would be revised very soon. So there is a room. So this is a good hope for us, because the mechanism of remdesivir cannot be affected for different variants. So other modalities of therapies, including vaccination, can actually affect the variant. I mean, the variant can have an effect on therapies, including vaccines, whereas it is not affecting antivirals like remdesivir. So the other therapies in this group where the viruses, where you want the viruses not to incorporate into our tissue, it is used by blocking monoclonal antibodies. So logically, monoclonal antibodies are very good in early phase of therapy, and it has been shown. So the different pharmaceuticals have shown different monoclonal antibodies, but unfortunately, some of the monoclonal antibodies were rejected because Omicron has bypassed the area of impact. So the only monoclonal antibody which WHO have made as conditional recommendation is sotrovimab, based on this data. So it still has an effect on Omicron variant, which is the largest circulating variant. So another conditional recommendation, and it's a new antiviral, pure antiviral everybody is talking about, for patients who have mild and moderate COVID, meaning not hospitalized, is Paxlovid. So Paxlovid is a combination of antiviral together with ritonavir. So remember, ritonavir is a drug we use for HIV, but alone it has nothing, it doesn't have an effect on COVID-19. So to make it short, it acts on proteolytic change, so it is a protease inhibitor of the viruses. So what are the pros and cons, and what did the FDA approve it for? So it is authorized for patients with mild to moderate and age group of more than 12, but for those at risk for progression for severe disease. Otherwise, it is not recommended for severe to critical COVID, and it is not recommended as pre-exposure without patients at risk for progression, and not longer for 5 consecutive days. So other antiviral, again, was given emergency authorization, which I personally don't really like. It is a prodrug. What the mechanism of action, it is called Molnupiravir. So mechanism of action is it incorporates into the genome and subgenome RNA, and it creates mutation. So it creates mutation of the virus, in that mutated RNA sequence would be the template and replicate. So this mutation is believed to cause non-functional virus, but the studies also show that it has a risk for cancer formation and mutagenesis, and it is not recommended for pregnant and lactating mothers. So the benefit and the risk, especially where we don't know which group of patients actually progress to severe disease, makes this a less likely option. So when we talk about outpatient, because of logistic issues and availability of hospitals, some of patients might not actually be admitted. For those kind of patients who are discharged from in hospital setting because of lack of bed and so on, the recommendation is to continue remdesivir or dexamethasone, but still acknowledging that there is a weak evidence related to that. So for those discharged from hospital setting but in a stable condition, then the recommendation is against using all these medications listed here. So this is what I initially said. But if those patients who require increment need of supplemental oxygen, then the panel recommends dexamethasone to continue for the duration of oxygen supplementation, and I will go how we are going to supplement oxygen later on. So therapeutic management of hospitalized COVID-19 patients, again, I will try to summarize for the interest of time. So for any other reason, if COVID patient is admitted but does not require oxygen, then what you should give is only prophylactic heparin and then manage the reason why the patient is admitted. Otherwise, it is not recommended to give a steroid for those who doesn't require oxygen. But for those who are admitted and require supplemental oxygen, then evidences are you start patients with dexamethasone based on recovery trial, and everybody is doing it. It has a very good mortality outcome. But there is also evidence of giving remdesivir. Remember, remdesivir also works in this group of patients with overlap of viremia as well as involvement of the pulmonary system. So combination of dexamethasone and remdesivir, level of evidence is B2B. But for those patients on remdesivir and dexamethasone and rapidly increasing oxygen requirement, then you need to give, based on evidence, immunomodulatories, meaning immunomodulatories are those who modulate your immune system and which have actions on interleukin-6 receptors, and or immunomodulatories like baricitinib, which have JAK inhibitors. So the pathway is similar for interleukin-6 receptors and JAK inhibitors. So you use it either or. So you don't use both therapies together. But what is interesting, and I will come to that later again, is the use of therapeutic dose heparin. Despite lack of evidence for VTE, therapeutic dose heparin actually showed benefit for those patients who are not on mechanical ventilator. So patients who are requiring mechanical ventilator here, then you go down to prophylactic dose of anticoagulation. So other therapies, dexamethasone together with first line is tocilizumab. So tocilizumab is, as I mentioned earlier, it is interleukin-6 receptor blocker, and WHO actually have strong recommendation for interleukin-6 receptor blockers. So you can get the details in the guideline. So just to mention on antithrombotic therapy, because we did pragmatic overview and represented low and middle income countries, our team, I was actually the PI of the publication. So we did a thorough research of practice in low and middle income country, and VTE events were very high as opposed to previous acute infections and even surgery. So it is shown that heparin products, as opposed to other antithrombotics, have additional antiviral and anti-inflammatory effects. So this is what I said, anticoagulation, therapeutic anticoagulation based on this study, has shown benefit for patients which are not critically ill. But once they are critically ill, then actually the damage is more than the benefit, and the bleeding risk is high. So other time-tested interventions is obviously oxygenation. Oxygenation target is different for different individuals, but we stick to 90% of oxygen, but knowing that between 90 to 94, especially between 90 to 92% of oxygen is not normal. But when we supplement, so the range should be between around 94 to 96. So there are some evidences that more than 96% target is not, does not have a good outcome, but also limiting oxygen to less than 88 to 90 was also found to be bad. So the other is proning. So we can talk about proning all day long. So you definitely should be included both for awake and intubated individuals, provided you have a good support of doing it. So awake, you can make it intermittent within 2 to 3 hours, whereas intubated, it requires a longer duration to have those mortality benefit. So ventilation, again, time-tested lung protective ventilation with low tidal volume of 6 cc per kg, where you maintain the plateau pressure of less than 30, cannot be beaten. So you can individualize to have a standard there. Otherwise, ventilation, follow-up of monitoring of patients on ventilation is very important, and definitely do no harm come first to have a support on top of oxygenation to give ventilation. So the other is restricted fluid for patients. But what is very close to my heart is the use of antibiotics. So we talk of autopsy studies. It has shown that up to 32% of patients can have concomitant bacterial infections, but it does not differentiate between community-acquired pneumonia versus hospital-acquired pneumonia. So this is a very good study which has actually the only study who did bronchoalveolar lavage in early, within 48 hours of intubated patients, and they found that significantly lesser number of bacterial superinfections, where most of them are sensitive to antibiotics and they are not resistant. So it is not recommended. So there was a big review done assessing different countries in African countries, 10 countries where Ethiopia is also included. They assessed our guidelines. So our guidelines, almost all of us, does not follow the proper guidelines. So WHO does not recommend the routine use of antibiotics, especially for mild and moderate. So WHO again not recommend azithromycin, and WHO strongly recommends based on watch and reserve list. So what is that? So 2021, they did an AWARE classification. So assess, watch, and reserve antibiotics group. So in access group, this group of antibiotics have a wide range of coverage, but lesser resistance potential. So these are ampicillin, amoxicillin, clavulanic acid, first generation cephalosporins, doxycycline, and cotrimoxazole. Whereas in the watch group, which here we use right and left, is azithromycin, carbapenems, different forms including meropenem. Second generation cephalosporins are in the watch list. They have a high resistance potential, and that can create a problem in the future. So the other reserve are actually, most of them are not available in our country. So when you talk of the future pandemics, you talk of drug resistance. So we might not be able to treat even sore throat if we continue using antibiotics like this. So it is going to be, so lots of fund is being mobilized to assess antibiotics resistance pattern. So by now, more than 2 years, close to 3 years, COVID, we are now seeing complications of long COVID. So there is a definition by WHO So the timing was different for different guidelines. NIH CDC uses 4 weeks, but for WHO they use 3 months from onset of COVID-19. If patients' symptoms usually lasting more than 2 months, these symptoms can be persistent or can even be a new onset of symptoms, but usually these symptoms cluster together. So this is quite common. So common in a sense, it affects almost every organ. So the commonest manifestation here you see is dyspnea. So dyspnea is the commonest manifestation, whereas neuropsychiatric manifestations are also common. So what are these risk factors? Which group of patients actually develop this long COVID? So different researchers did a study. So number 1 cause is initial viremia. So those patients who have severe illness and related to high viral load or at more risk, but other pre-existing respiratory disease, high BMI, older age, and minorities like Black, Asians were found to have more long COVID symptoms, and women are more likely to experience fatigue and anxiety at 6 months of follow-up. So the potential mechanism is a lot. It can be virus specific or immunity change aberrations, which are more favored, but also there can be expected sequelae of post-critical illness. So, so in a molecular level, a study done and published an article of Cell has shown that, you can see it here, so has shown that human herpes virus reactivation is also one of the pathogenetic mechanisms. And also initial IgG and IgM, if it is low during acute COVID, then these patients were found to have long COVID. Other mechanism is GI dyssymbiosis. So there are lots of evidence being gathered related to those who have GI dyssymbiosis, meaning beneficial pathogens are less and more pathogenic organisms are more residing. So antibiotics also is contributing for the dyssymbiosis. So as I said, dyspnea is the commonest manifestations. Persistent hypoxia and requirement of CPAP is also high. So how do you follow patients who have dyspnea? So at 4 to 6 weeks, so you do clinical and respiratory assessment. So you make sure that this is not deconditioning. You do functional tests as well. But so if you still symptom persists, so usually around 12 weeks, based on the definition, you do further tests like chest X-ray, full pulmonary function test, and you do functional tests like 6-minute walk test. Also, you rule out cardiac causes with echo, and you do high-resolution CT scan. So the commonest finding is ground glass opacities and organizing pneumonia-like feature. So what do you do for these patients if you have organizing pneumonia and what looks like ground glass opacities on their workup? So this is a study which they tried with steroids. So how much steroid did they use? Because this is easy for us to do. So the maximum dose, so they had interstitial lung disease multidisciplinary team. So the maximum initial dose they used was 0.5 milligram per kg. So the average was 26 milligram. You can see it by week. And they quickly taper it over 3 weeks. So they showed significant difference. So the other is chest pain as a manifestation. So autopsy have shown that 60% of patients can have the viruses in situ, but there is also subsequent inflammation, cardiomyocyte and replacement of desmosomal proteins with fibrofatty displacement. So that creates a scar and perpetuates arrhythmia and palpitation. And also, just like any other viral infections, they are at risk for postural orthostatic tachycardia syndrome or inappropriate sinus tachycardia. So for this group of patients, and beta blocker, low dose beta blocker has been tried. So other manifestations is neuropsychiatric, up to 30 to 40% of survivors. So rehabilitation is very important in understanding these patients is very, very crucial. So the other is renal. So we know up to 5% can have renal effect for all hospitalized, and 20 to 30 of critical patients can have AKI. But reported reduced GFR were found to be up to 35% in 6 months follow-up. And COVID-associated nephropathy was found to be the pathogenesis with collapsing type of FSGS pattern, especially in African descent, and it was linked to APOL1 gene mutation even in COVID-19 survivors. So new reduction of GFR was also found. Up to 13% of survivors in a China study showed a new reduction of GFR defined by less than 90. So the other is endocrine. So it's alarming rate of diabetes have been witnessed, but also subacute thyroiditis and bone demineralization for various reasons have been shown. So thyrotoxicosis, Graves' disease, and so on should be tested based on patient clinical manifestation. So the other is GI. So fecal viral shedding can be persistent. It can alter gut microbiome. Malnutrition is also part of the abnormalities. From dermatology, the commonest is hair loss. So patients can complain, 20% of patients can complain of hair loss. So it requires interdisciplinary management. So all the hematology, persistent thrombosis, and DVT-PE is a risk. So dyspnea and persistent oxygen requirement is the commonest manifestation, but also follow-up in renal and primary health care for rehabilitation and patient advocacy groups. So all these definitions started from WHO by asking patients. So it was a patient-centered assessment which led to the identification of long COVID. So for low and middle income countries, there were a move to use repurposed drugs to manage long COVID. So for dysautonomia, it was proposed to use beta blockers and benzodiazepines. For coagulations, anticoagulants. And for excess inflammatory response, you can use H1H2 antagonists and leukotriene inhibitors. And it is a good article which summarized the role of repurposed drug for low and middle income countries. So let's talk about few challenges. So in our setup, tracking and studying variants is a problem. So tracking and studying implies genomic surveillance based on sequencing. It should be on time. The other is genomic epidemiology, associating these genomic sequences to clinical health, to clinical relevance. So that can have an impact on confidentiality, and that's going to be our future challenge. Other challenge is human nature. So human nature is very difficult to handle. So masking is a problem for all of us, including ourselves, and understanding and trust of the community is very important to adhere to evidence-based medicine. But some countries are leading the fight. So this is a picture taken from Hong Kong in 2008, and they were actually using face masks then for patients who have respiratory symptoms. And look at the distance in between as well. It is in 2008. So the control in Hong Kong and personality is actually very impressive. So the other unfortunate weakness is our gap in economy. So initially the founding of WHO, this is a slide shared by one of my teachers in New York, and it's WHO, as you know, was first. This is a New York Times magazine during the establishment of WHO in 1948. So the goal is to have improved world health. So let's see the funding of WHO. So it's less than 4 billion annually. So it's up to 3.7 billion annual based on the proposed budget in 2020 and 2021. And now let's look at the annual budget of one hospital, representative hospital in New York City. So we had the privilege of going to both of these hospitals for our fellowship, and look at the revenue. for one. It is 6 billion, more than 6 billion total functional revenue for a single New York medical center. So the discrepancy between funding and this funding distribution for the minorities, blacks, is very different. So social discrimination, so we might be in the same storm, but definitely we are not in the same boat. So thank you very much.